drowsy. Then as they continue taking until even when they take 10 bottles and they are okay, you didn't know that they've taken alcohol. Yeah, so they become used. So because the anesthetic agents work in the same areas that, or in the same cells that in the brain that the alcohol depresses, then it means they are used to, since they are used to alcohol intake, then they would need more of these anesthetic agents to go to sleep. So that's one of them. The other factor is thyrotoxicosis. And from what we've learned about in thyrotoxicosis in medicine, is that patients with thyrotoxicosis, they have increased basal metabolic rate. So substances are metabolized very fast. So then it means even these drugs will also be metabolized very fast and removed from the body. So then you need more to keep the patient asleep. Then the other one is decreasing age. It has been found that children require more of the anesthetic agent compared to adults. That one is a study that needs to be done as to why smaller children or young people will require more of the anesthetic agents compared to the older ones. Then the other one is pyrexia. Pyrexia also increases the mark. A patient who has fever will need more of the anesthetic agents. And again, when we put it in the way we've done with the hydrotoxicosis, we know that pyrexia again increases the BMR. It increases the basal metabolic rate, meaning again that when the patient is febrile, the metabolic rate is high, and then again the drugs are being metabolized quite fast. Then again, there are drugs like ephedrine, amphetamine. All these will increase the mark. So these are substances or factors that will increase mark. Then we have factors that will reduce mark, and so factors that reduce mark, meaning that if a patient has this, it means then they will need less of the anesthetic or the volatile anesthetic. And one of them is pre-medication. Remember when we talked about pre-medication, we said that it enhances anesthetic such that you need less of the anesthetic to put the patient to sleep. So if your patient is well pre-medicated, has been given analgesics, has no pain, is not anxious, it means they will need less of the anesthetic agents to go to sleep compared to a patient who is apprehensive, a patient who is anxious, a patient who is in pain. So we say that pre-medication with analgesics or anxiolytic reduces mark. Then the other one is nitrous oxide. Normally when we put this patient to sleep, we usually want to combine oxygen with nitrous oxide, because that way, since nitrous has been found to reduce mark, then the patient falls asleep faster than when you induce them with just oxygen alone. Then we talk about decreasing age. Then again, it also means that in a patient who is older, the mark would be reduced. Hypotension also has been found to decrease mark. Hypothermia, of opposite of pyrexia, and then myxedema. Myxedema is also opposite of thyrotoxicosis. All these will reduce mark. So it is important now to, at least these are things that you may need to really, I don't know, understand them. And maybe, I don't know whether it's cramming or understand, we need to understand them, so that this is something that you may be needed to remember at some time. So those are the factors that increase mark and factors that decrease mark. Again, pregnancy is another one that decrease mark, hypocapnia, and all that. Then we can ask ourselves, so what is the clinical implication of mark? Why do we clinically want to know mark, to understand what is this minimum alveolar concentration? And one is that understanding of mark, it helps us prevent awareness. Okay, there are patients who you put to sleep, but they are aware, they are not deep. So you've sedated them, or you've given this inhalation or anesthetic agent, but the patient, you've not given enough, so the patient is aware. So there are some patients we operate on, and when the patient wakes up, they say, like, I could hear you talk, I could hear you put things being put in my abdomen, but because maybe they are paralyzed or because they are unconscious, they cannot complain. They are paralyzed, so they cannot lift, maybe complain or move, so that they can know that they are feeling pain, or they are feeling what you're doing to them. So that is what we call awareness. There are patients who have complained of awareness, and actually there are patients who have even told you what you said. So they tell you, you are saying this, you're even discussing my condition. So, and we don't want that. We want amnesia. Remember, we said that this anesthetic agent should cause amnesia, so that the patient does not recall what has happened during anesthesia. So we are saying that by understanding mark, it helps us prevent awareness, so that if I'm using drug X, the mark of drug X is 1%, meaning that then you need to give this patient at least 1% of the anesthetic agent, so that you prevent that awareness. So that, because if I give this amount of drug to the patient, then the patient will be completely unconscious and will not be aware. So it helps us to prevent awareness. Then the other one is a tool to measure anesthetic potency. So it helps us to measure the dose of the drug, or the potency of the drug. And we were saying that then a drug which has a higher mark, it means it is less potent than another drug which has a lower mark. So it helps us to measure anesthetic potency. And again, also helps us to study the side effects on anesthetic agent at equivocal dosage. So that you can know what are the side effects of this drug when I give this much, and what are the side, because there are some drugs we say it can cause this in increased doses. Yeah. So that's one of them. And the other one, it also helps us to know that combinations are addictive. That is, if you cannot when you combine two drugs, like you using allodane and you are using isoflurane, combine both of them, then it means then it's a kind of synergy. Okay, they are going to increase the potency. You're going to get more of what you need. So combinations are addictive. So this is the clinical implication of understanding mark. So then we look at the mark of or different anesthetic agents, or volatile anesthetic agents. And so this the mark of common inhalational anesthetics. Nitrous oxide is a poor. We're going to see that nitrous oxide is a poor analgesic. So it's a poor anesthetic. Okay, please note that nitrous oxide is a poor anesthetic, and that's why the mark of nitrous oxide is it is 105%. Okay, it is 100. This is a percent. It's 105%. Then the mark of allodine is 0.75%. Isoflurane is 1.2%. And then we have sulfofurane, which is 2%. And finally, we have enfurane, which is 1.6%. So this is we say that we measure mark in percentages. So then it means that if you give a patient allodine at 0.75%, then it means that 50%, for example, if you give 100 patients, it means that 50 of these patients will not move due to a surgical incision. So this is the mark of the we can say this is the minimum dose you can give for these inhalational anesthetics. Yeah, then a bit of history there, that about these anesthetics. Either was the first used anesthetics, and I'm sure even maybe in high school, when in chemistry you learned about either, and either was used were first used in 1844. Then I talked about chloroform, when we were saying that maybe that's what you used to do to anesthetize those animals you used to dissect in high school. Then it was in 1847. Then we had ethyl chlorides in the 1920s. We have these ones, we don't use them now, by the way. They've been out what by these new ones, which are better, they are safer, and they have less side effects. So these ones were used earlier, but now we are using the ones we've mentioned, their mark up there. So this anesthetic agent, these inhalation anesthetic agents, they are classified into ethers and halogenated hydrocarbons. So among the ethers that we use today is enfurane, and it was first used in 1973. Actually, I've not used it. Yeah. Then we have isoflurane, which is first used in 1980. We use this one a lot now. Then sevoflurane from 1990. In some places now, some hospitals, these high-end hospitals, you can get sevoflurane. Unfortunately, it is quite expensive, such that for 30 minutes in the place where we have it, like they charge, the patient is charged for every 30 minutes of use of sevoflurane, the patient has to pay at 8,000. So you see that is quite expensive in a big hospital. For maybe 3 hours. So that will mean about 6 times 8, that's around 48,000, which is quite an amount. Then we have desfurane. Desfurane is not even around in Kenya, but it is a good anesthetic. Unfortunately, it needs an electric perforizer. Then we have the halogenated hydrocarbon. So we are seeing this inhalation anesthetics are classified into ethers and halogenated hydrocarbons. And we're saying all the others, the isoflurane, the enfurane, the sulfur, and desfurane are all ethers. Then we have halodene, which is an halogenated hydrocarbon, and it is an odd one. Actually, we've used it for time in memorial, but now it's been phased out by these newer ones, which are also safer. So there is no hospital you'll go and miss halodene, yeah? But so these high-end hospitals, they are trying to not to use it. These days it's not being used often. It has been replaced by sevoflurane. And we're going to see why we still need halodene if you don't have sevoflurane, because all the others, all these other ethers except Cephor, is that they irritate the airways. They have a pungent smell. So then means it would be not easy. You cannot induce a patient with it. A patient who is awake, you cannot induce it because they will not agree to inhale that substance which is pungent, which has a pungent smell, and which irritates the airway because they will be coughing and sneezing. So so that's why we still use halodene when we have to induce patients, especially in those places we don't have sevoflurane. So then we look at halodene, and halodene is a colorless, sweet smelling liquid. So they say it is sweet smelling. I don't know. Um, I don't think it is actually sweet smelling, but at least it doesn't irritate the airway. So patients really can be able to bear with it as they get induced with halodene. It is decomposed by light, and normally they are usually stored in amber colored bottles, and of course a preservative called Dymo is added. Amber colored brown, it's a brown bottle like that one where the beer like Tusker is put. That is amber colored, so that it protects the sunlight getting to the liquid. It has a high blood gas solubility, so it's not a good anesthetic when it comes to the solubility. In that way, so it means induction will be slow because it has a high blood gas solubility, and also recovery. So the patient recovers. Like if you are maintaining the patient asleep with halodene, then it means it will take time after you stopped the halodene for the patient to regain consciousness. Then it is non-irritant to the airway, and that's why we use it a lot to induce patients. And 20% of it undergoes hepatic metabolism, and it's excreted in the kidneys. So what are its effects in the respiratory system? It's non-irritant. It causes bronchodilation, so then it is good in asthmatic patients, and it depresses respiration, leading to a reduction in tidal volume and increase in respiratory system. So when you do see this patient with this allodine, is that the tidal volume becomes low, reduces, but the patient tries to breathe faster, of course, to counteract that low tidal volume. Then it depresses the laryngeo and pharyngeal reflexes, which is good especially for intubation. It inhibits salivation and bronchial secretions. Yeah. So again, it's good because you stop, the patient do not salivate a lot, and also it increases the it reduces the mucociliary function. Yeah. So it reduces the mucociliary function. What that means is that you know that in physiology, I'm sure, of the respiratory system, you learn that there are those cilia, those hairs in the respiratory tract, which usually beat upwards, so that they can remove secretion and sputum. They can push secretions and sputum towards the throat, so that they can be coughed out. Yeah. So now we say that it reduces that. So now, since it reduces this mucociliary function, then it means that it may lead to sputum retention in postoperative period. Yes. Then in the cardiovascular system, it causes myocardial depression, causes vasodilatation, and this vasodilatation is usually useful for us, especially, remember I told you that we use these inhalational agents, especially in children, to put them to sleep, because sometimes it may be difficult to put a branula in a child, because they are crying, they are not cooperating. So normally what we do is that we put them to sleep with the inhalation or anesthetic, and then after they are asleep, we can now look for a cannula. And of course, then we are saying that this allodine causes vasodilatation. So if there is vasodilatation, then it means the blood vessels vasodilate and you can see them easily. So it makes cannulation easier. Then it increases the heart rate and causes myocardial excitability. And we find that with allodine, the patient may get arrhythmias. And then we say that it sensitizes the myocardium to catecholamine, causing arrhythmias. Remember, in the ideal anesthetic agent, the properties, we say that a drug which is ideal should not sensitize the heart to catecholamine. And remember, when I was explaining about this in anesthesia and surgery, when I was saying that when maybe a surgeon is removing a mass like a breast or maybe a lipoma, they normally, or even maybe doing neurosurgery and cutting through the scalp, they normally inject something I call jungle juice. I hope you can remember that. And we say that this jungle juice, one of the components of the jungle juice is adrenaline. Okay, because you want to cause, adrenaline is a vasoconstrictor. So you want to constrict the blood vessels around where the surgeon will cut, so that you reduce the bleeding. Okay. So then it means if now, for example, the inhalation or anesthetic you're giving sensitizes the heart to catecholamines, and because now these catecholamines, adrenaline, epinephrine, they cause arrhythmias. And then you have another drug that also causes arrhythmias or sensitizes the heart to these catecholamines. It means that the arrhythmias that you get when you combine adrenaline with allodine, it means the arrhythmias will be much more. So then we normally don't want to use both at the same time. So when the surgeon is giving that jungle juice, then we want to use another volatile anesthetic, or we want to reduce the dose of allodine if you are using it, because of that sensitizing the heart to catecholamines, and now that one leads to arrhythmias, which might be fatal. Then in the central nervous system, it increases the cerebral blood flow. So and again, it's not good for neurosurgery, and abolishes autoregulation, that autoregulation of blood pressure and all that. And then in the uterus, causes relaxation of the uterus, and it may cause PPH. So it's not good for patients who have just delivered. Maybe a patient has delivered has retained placenta, it is not good to use in such patient because the uterus continues being atonic and the patient may bleed, leading to postpartum hemorrhage. In the GIT, it reduces gastric motility. It reduces gastric and intestinal motility. What about in the skeletal muscles? Causes muscles relaxation, and it potentiates muscle relaxants. So if you give muscle relaxants and combine with allodine, then it means the effect will be more. So meaning that if you are using allodine together with a muscle relaxant, then you may have to reduce the dose of the muscle relaxant. It causes shivering, and sometimes in the patients in the in the recovery room, you find them shaking, and we call them allodine shakes in the post-op period. Then also it triggers something we call malignant hyperthermia. Malignant hyperthermia is an inherited, it's a condition that runs in families. You can say it's genetic, and it's quite fatal again, that normally these patients who are prone to that or are predisposed to this, when you give them allodine and other anesthetic agents, then it may trigger this malignant hyperthermia. And normally what happens is that these malignant patients become very febrile. From nowhere, the temperatures go to like 41. Then they start twitching. They start sweating, and sometimes it is really hard to bring them back. They may get a cardiac arrest, and it's been really hard to get them back. And that's why, remember, even when we were introducing anesthesia, we say that when you take history, then it's good to know whether relatives have had issues. Maybe sometimes we tell the relatives that you people are prone to malignant hyperthermia. So that's why we say it triggers malignant hyperthermia in susceptible patients, those patients who have that genetic predisposition. Then it may cause what we call allodine associated hepatic dysfunction. And normally what happens is that repeated use of allodine on patients may cause dysfunction of the liver. And we've seen these patients coming with jaundice. Okay. Normally, it causes a mild subclinical type of transient derangement in liver function test, and also increases the GST. It may cause severe jaundice, which progress to fulminant hepatic necrosis. So then again, we cannot repeat it. Like patients who are going to theater often, you cannot repeatedly use allothen, because it may lead to this hepatic dysfunction, which is associated with the allothen. Then now the other, so that is allothen. Allothen, we use it a lot, and every anesthetist has used allothen. Then enfurane, it's a clear with a pleasant ethereal smell. It has that smell of ether. Okay. 2.5%, it undergoes hepatic metabolism, predominantly to fluoride, and which may also affect the renal function of patients. And at moderate high concentration, it produces epileptiform activity. That is, if you give moderate to high doses, the patient may get epileptic fits. There is less incidence of hepatic dysfunction and arrhythmias compared to allothen, and it may cause cross sensitization with allothen. And again, it might interact with allothen. And furane is not used often. Actually, I've never used it, so it is not common in our setting. Then we have isofurane, is the other volatile anesthetic. It's also colorless, volatile liquid with a pungent smell. So isofurane has a pungent smell, so then you cannot use it for induction of patients. A small amount of it undergoes hepatic metabolism, and arrhythmias are uncommon. So normally what we do is that if as the surgeon is using that jungle juice, and so you will normally want to put this patient on on isoflurane, because we see that unlike halothane, isoflurane does not cause arrhythmias, causes coronary vasodilatation, and may cause a condition we call coronary still syndrome. You can check it up. At low doses, it does not cause increase in cerebral blood flow. So we prefer isoflurane for neurosurgery compared to halothane, because it you use low doses, it reduces the cerebral blood flow. And I say that so when you're doing neurosurgery, because the brain bleeds a lot, the scalp bleeds a lot. So you want to use a drug that will reduce the blood flow to the brain, so that the patient does not bleed a lot. And the other anesthetic agent, the volatile anesthetic agent, is sevoflurane. This one has a pleasant smell. So actually, this is what replacing halothane for induction of anesthesia. It has a low blood gas coefficient. So you can see it has a pleasant smell, and also it, unlike halothane, which has a high blood gas solubility, sevoflurane has a low blood solubility. So the induction is usually faster, it is smoother, and again also the reversal or the recovery is also faster and smoother than when you use halothane. 5% of it is metabolized in the liver to fluoride and of course that not necessarily something to remember. Then it is degraded by both soda lime and bala-lime. Yeah, so the effect is reduced by soda lime. I talked about soda lime and bala-lime, and these are substances or pellets that absorb carbon dioxide in a closed circuit. The other one is desfurane. This one I've not seen it. It's quite expensive, and also you need an electric perforator to use it. It has the lowest blood gas solubility, so it is the best when it comes to induction and reversal. It is the best because its blood gas solubility is the lowest. A little amount of it undergoes metabolism, and it is irritant to the airway. Unfortunately, so you can't use it for induction, causes tachycardia at high concentration, and we see that is expensive and required an electric perforator. So those are the volatile anesthetic. These are the substances that we use to either induce the patient, but mainly these volatile anesthetics are used for induction, for maintenance of anesthesia. After you put your patient to sleep, maybe with ketamine or with propofol or with sodium thiopentone, then because those drugs, we say that they take a short time, like up to 5-10 minutes. After 10 minutes, the patient is no longer asleep. The patient is no longer unconscious. So then you have to maintain this patient unconscious for the 3, 4, or 2, whatever 1 hour the patient is going to be, the surgery is going to take place. So we see that mainly these volatile or inhalational anesthetic agents are used for maintenance of anesthesia for induction of anesthesia, and especially in children. Then we talk about these other gases which we use together with them, and oxygen is one of them. And I'm sure all of us have know how oxygen is prepared commercially in chemistry. Is it from 3 that the commercial preparation of oxygen by fractional distillation of air? So air undergoes fractional distillation, and then at the end product is pure oxygen. Remember, the air with the atmospheric air has 21% of oxygen. So now if you want to get 100%, then you have to subject that atmospheric air to fractional distillation, so that at the end you can get 100% oxygen, and it's 100% oxygen that we use in hospitals. Okay, and we can also produce it in concentrators. I'm sure in hospitals you've seen that machine we call a oxygen concentrator. What happens is that it is usually connected to into the power, electricity, and then it can be able to produce some 100% of oxygen. So we can use that, and it was really useful at the time of COVID, when patients needed to be maybe on oxygen at home, that they could use that, or even use oxygen in cylinder. So we can, in small proportions, you can produce some amount of oxygen by using oxygen concentrator, and some hospitals, actually most hospitals, do have oxygen concentrators. The cylinders now, it's important to note the color coding. Now, the color coding of these cylinders for these gases are specific for that gas, such that if you see a blue cylinder, you don't need to go and read what it contains. If you see a black cylinder with a white shoulder, then again you know that this is oxygen. Okay, so then the color coding for the gases are usually specific for the gas. So for example, oxygen will be stored in cylinders that are black body, all the way from the shoulders. From the shoulders going down, it is black, and from the shoulder going upward to the head, it is white. So it for oxygen is black with white shoulders. That is the color coding of oxygen. And what are the uses of oxygen in anesthesia? One, we use oxygen to pre-oxygenate patient before induction. So before we induce the patient, before we give the propofol, the ketamine, we want the patient to breathe. Remember, we are breathing 21%. We want the patient to breathe at least 100% of oxygen. So normally we want to put that mask on the face of the patient to breathe at least 3 times, three breaths, so that at least it can raise the SpO2 to around 100%. Because I say that between the induction and insertion of the endotracheal tube, there is some time where the patient is not breathing. So we want at least to have a good receiver of oxygen before, because it may take time before the tube goes into the trachea, and the patient can now start getting oxygen. So we use it in anesthesia for pre-oxygenation before induction. Number two, we use it during general anesthesia. And also during regional anesthesia, there are sometimes we supplement the patient with 100% oxygen. Then all general all patients who have been given general anesthesia, in the recovery room, we also want to give them oxygen until they can be fully awake. And also sometimes it's used in patients who have hypotension, hypertensive patients. You can use it as a prolonged therapy. Patients with ischemic heart disease, patients with anemia. Anemia, again, remember, there is not enough hemoglobin to transport the oxygen to the tissues. So then it means that you want to increase the concentration of oxygen, so that the few hemoglobin that are there can be able to be fully occupied with oxygen, so that the patient can get enough oxygen into the tissues. Then obesity, also patients who are obese because of the airway obstruction that they get because of the obesity, you again want to supplement oxygen. Patients who are shivering, because shivering increases the oxygen demand. When you're shivering, the metabolic rate is high, you need more oxygen. Otherwise, it's just like even when you're running. When you're running, you are using oxygen quite fast. So you need oxygen, so metabolic rate is high, so you need more oxygen. So patients who are shivering, the same. Then again, patients who are hypo or hyperthermic, again, you also need to give them more. Patients with pulmonary edema, patients with airway obstruction. So these are times when oxygen may be needed in prolonged therapy. You give patients oxygen for a long time. Then again, because there is no drug without side effects, even oxygen has side effects. And one of the side effects is that it supports combustion. So no, if you put it somewhere where there are fires, it may support the fire and may cause fires. Then it causes something we call absorption atelectasis. Now, when you give 100% oxygen to a patient for a long time, it causes collapse of the alveoli. We call it absorption atelectasis or lung collapse, where the alveoli collapse. So we don't want to give 100% oxygen for a long time. And normally that's why in anesthesia we want to combine it with either medical air, or we want to combine it with nitrous oxide. The other one, it can cause carbon dioxide narcosis in patient with chronic CO2 retention. So the patient retains a lot of carbon dioxide, then they may get depression of the respiratory system. Then may cause pulmonary oxygen toxicity, a condition we call Rodin-Smith effect, which is usually second to inhalation of high concentration of oxygen. And this one leads to the patient presents with edema and fibroblastic changes in the alveolar and the interlobular septa. So all these are side effects of oxygen. So we can say that, we usually say that there is no drug without adverse effects. There's no drug without side effects. So just a moment. Yeah, so sorry. Yeah, so those are the advanced effects of of oxygen. Then we also have something we call fibroblastias in infants. So it causes retinopathy in infants. So again, especially in infants, we don't. That's why you find in pediatrics they are not giving a lot. They are giving like 2%, no, 2 liters of oxygen. They don't want to give high flows of oxygen because of this effect on the retina of the infants. Then it may also depress hematopoiesis and may cause myocardial depression and conversions, or those side effects of oxygen. Then nitrous oxide is another gas that I said we use, and it's obtained from ammonium nitrate, normally stored in blue cylinders. So nitrous oxide is normally, if you see blue cylinders, the cylinder is all blue, both the body and the shoulders are blue, so that is nitrous oxide. And this, it's important, this color coding. Normally you may get a question in MCQ, like what is the color coding of, what's the color of nitrous cylinder, so it's important to really understand them. It has a sweet smelling, so it has a sweet smell, and it's an irritant and a colorless gas. So it's a gas that is sweet smelling, which does not irritate the airways. It supports combustion in absence of oxygen, and it's a good analgesic. One good property about nitrous oxide, it's a good analgesic, but we said it's a poor anesthetic because you see that the mark is 105%. So it is a poor anesthetic, but a good analgesic. It is not metabolized in the body, so it is removed again and changed. So the gas, after it does its work, it just goes back to the lungs and it's exhaled and changed. So what are the uses of nitrous oxide? It potentiates inhalational engine. We've said that it decreases mark. So it potentiates inhalational engine, meaning that if you're combining nitrous, using nitrous with this inhalational engine, then you need less of the inhalational engine because it enhances. In other words, we say that it reduces mark. Okay. Then it's a good analgesia and sometimes may be used as an analgesic. And number three, it is used in some combination we call entonox. Entonox is a combination of 50% nitrous oxide and 50% oxygen. So it's also a gas which is usually in cylinders that have the shoulder is white and the blue quarters. So the cylinder of entonox as stripes that are white and blue, but the body is blue. Okay, we call so those are endonox, small cylinders. We used to use it before. I used to see it in labor wards, whereby it was used like analgesics for labor. So what would happen is that the cylinder would be there, like you see those cylinders in pediatric ward where which has so many flowmeters, and then there are those oxygen tubings connected. So what would happen is that the mothers, when they are going to do labor, when they start getting the contraction, then they would take the mask. So everybody have their mask, then they connect the mask to the mouth, so they breathe in and out, breathe in and out, and then it takes care of that labor pain, those contraction pains. Then after the pains have subsided, then they stop breathing the entonox. Then again, so it is actually used for labor analgesia. So we call it entonox. It has shoulders that are white and blue, and the body is blue. And we say that it is used for obstetric analgesia. Can also be used for wound dressing. Remember, imagine like in the pediatric ward, or even in the surgical wards, you're dressing patients with burns. So normally that time you're doing the dressing, so you put the patient on this mask and they breathe in the entonox, and then it takes care of pain. It acts like an analgesic. And we have said that entonox is 50% nitrous oxide and 50% oxygen. Also used like when you remove chest drains or doing dental surgeries. That is entonox. Side effect of nitrous oxide: it may cause diffusion, hypoxia during reversal. Now, before, our anesthetic machine was that you could give nitrous oxide without oxygen. Like you put on you put on the nitrous oxide without oxygen, and it would continue, you would deliver nitrous oxide. But now the machines we have these days have a saved measure such that you cannot give nitrous oxide without oxygen, meaning that every time you're putting on the nitrous oxide, the oxygen also goes up. Okay, so there's no way you give nitrous oxide. But before the machines we had, you could give any of them. So then maybe sometimes you forget when you're reversing the patient, because when you reverse the patient, we stop all the other drugs. So we put off nitrous oxide, we put off the maybe iodine isofurane, and give the patient 100% oxygen. So sometimes maybe somebody is tired, or they would maybe forget and put start reversing the patient with nitrous oxide. So meaning that this patient absorbs the carbon dioxide alone. So that's why we are saying it can cause diffusion, hypoxia, because it will diffuse into the tissues instead of oxygen. Then the other one, it has effects on closed gas spaces. Now, there are those areas that are closed air spaces, you know, like for example, if you're operating in the ear, here we have the middle ear is usually a closed air space which contains air. So when the surgeon is working on the ear, maybe like putting a graft. Now, when you use nitrous oxide, it increases the pressure in those air spaces, and then it can remove that graft. Maybe a patient has a perforated eardrum, and you're putting a graft on the eardrum. If you use nitrous oxide, it increases the pressure in those closed air spaces, and the graft can come out. Maybe also patients with pneumothorax, like they have air in the chest, it can also increase the amount of air in that chest. So again, we also don't want to use in patients with such conditions. So normally in ear surgeries, whereby maybe like a surgeon is doing mastoidectomy, or doing those tympanoplasty, normally after the graft is put, you want to put off the nitrous oxide and maybe use the medical air. Then it can cause myocardial depression and also affects vitamin B12 synthesis. And that's why we are saying that it depresses hemopoiesis. Yes, you see that it depresses hemopoiesis. So so then, because this enzyme, the B12 synthesis, the methionine synthetase usually helps in hemopoiesis. It's one of the enzymes that is used in during hemopoiesis. Then it can also cause teratogenic changes, so it's not good in patients who are in the first trimester of pregnancy. Then the other gas we use is medical air. So medical air can replace nitrous oxide. It's actually cheaper. It usually comes with gray body, but in cylinders that have a gray body and a black and white shoulders. It has no analgesic properties. It is non-toxic and it's cheaper than nitrous. So you can use medical air instead of nitrous. Uses this medical air can be used to drive gas for ventilators. So our ventilators are such that they are driven by the gases. Yeah. And then we have said that we don't want to use 100% of, so you want to combine it with oxygen so that you don't give 100% oxygen. And of course, it's this now which drives the ventilators. Also, like in the pneumatic drills, you have some drills, like maybe the surgeon is drilling on the bone. They use some drills that are driven by gases. So this medical air is what is used. And also what you see in these Joakali places, you see those cylinders which are used kuchomelea, like exhaust. They use that medical air. Then in maintenance of anesthesia with oxygen, we see that we combine it with oxygen and volatile anesthetic. Then the other one is carbon dioxide. We also use carbon dioxide in theater, and we're using it more often now. Now, carbon dioxide comes in gray cylinders, small gray cylinders, and normally we use it for laparoscopic surgery. I'm sure you know now that most patients are preferring that laparoscopic surgery, whereby um, you don't have to open you don't have to open the abdomen. So you just put a few holes in the abdomen, and then you can put props in the abdomen, and through a screen you can be seeing what is happening. So you can remove the appendix by just putting those props into the abdomen, and you operate as you look into the screen. So that's what you call in the laparoscopic surgery. Now, carbon dioxide is usually put inflated into the abdomen, so that it separates the organ, so that the organs can be seen clearly. So that's how carbon dioxide is used, not actually in anesthesia. So there are some questions there, study questions, like list the properties of an ideal intravenous agent. What factors reduce mark? Write short notes on those. Compare and contrast allodine and iso. Those. So those are the other questions. I'll send the notes, so you should be able to go through them briefly for the next 10 minutes. I want to just do a bit of stages of anesthesia, um, so that we can understand. Now, these stages of anesthesia, they were studied with these inhalational agents that somebody called Boedel was able to monitor the stages the patient goes when you're inducing them with these gases. Um, Yes, so the stages of anesthesia, they were described by this guy called Guedel in 1937, and he describes the stages that the patient goes through before they sleep. Okay, and so he described 4 stages, and we can see these stages. They are series of signs observed from the onset of anesthesia to subsequent depth from uh, depth when using either. So he used either. Either is one of the, and I said it was used before. It's one of the volatile, and I said that was used in those earlier days. So in 1937, he was able to describe the stages of anesthesia using either. and he was able to find that there are four stages, and one of the first stage, stage one, he called it the stage of analgesia. And during that stage, now when you start inducing that patient with that allodane or that ether, the patient now we start with stage one, where now pain is taken care. So there's that during that stage of analgesia, normal reflexes are maintained. Normal reflexes will be maintained, and until now the loss of consciousness. So the normal reflexes are maintained until loss of consciousness, and then the eyelash reflex is abolished, such that during that time stage of when you pass your hand through the eye, then the reflex is abolished. Then the stage two, we call it the stage of excitement. And normally we see this stage now as you continue now to give that child the allothen, they get a stage and then they become restless, they become excited. In other words, they'll become restless, they get the breathing is irregular. Yeah, they are restless, the breathing becomes irregular, they start struggling and restricting. So that's the time where you need somebody to hold the child for you, so that you can be able to continue giving the gases with the mask. So they are struggling and resisting, and then they may regurgitate, they may cough, and also they may have religious spasms during this second stage of anesthesia, which is the stage of excitement. And when you look at the pupils, they will be dilated. So during the second stage, which is excitement, there is excitement, the child becomes restless and struggling and resisting. They may hold the breath. You find that they may stop breathing, then they may cough, regurgitate, and there may be religious passing. Finally, you find that when you look at the pupils, they will be dilated. Then the third stage, he called it the stage of surgical anesthesia, and he divided into planes. And the plane one of the third stage was the eyes will be centrally replaced, and there is loss of conjunctival reflex. The swallowing and vomiting depressed. Remember, in stage one, we are saying that there will be regurgitation, coughing, and religious passing. But during this stage of plane one of stage three, those ones are depressed. The pupils becomes normal or small. In stage two, the pupils become dilated, but as they continue to plane one of stage three, they become normal or small, and the patient may start tearing. So there is increased lacrimation. Then the plane two of stage three, there is beginning of intercostal muscle paralysis. So the intercostal muscle starts getting paralyzed. So then what happens is that, remember, intercostal muscles are used for breathing. So the breathing becomes deep, regular and deep. So the patient now starts, remember, the breathing was irregular in last two stages. So in plane two, the breathing becomes regular and deep, and also the corneal reflexes disappear and the pupils dilate again. Okay, plane two, there is dilatation, but in plane one, the pupils had become normal or small. And then there is further lacrimation. Patient continue tearing. So when you see this patient tearing, it is just normal process of these stages of anesthesia. Then plane three, there is complete intercostal muscle paralysis. The breathing becomes shallow, because now you see now the intercostal muscles are paralyzed. So patient is just left with the diaphragm. So breathing now becomes shallow. The religious reflexes will be depressed, and there is a depression of lacrimation. Now lacrimation stops. And actually, we don't want, when you put our patient to sleep, we don't want to go past the third plane. Otherwise, the patient will stop breathing completely. And remember, during that time, maybe you're not breathing for the patient. Then now when you go to stage four, there is complete diaphragmatic paralysis. So the intercostal muscles are already depressed, paralyzed. Diaphragm is paralyzed, so the patient stops breathing. So meaning that you have to support breathing. And also the carinal reflexes are also depressed. Then you go to stage four. Stage four, we should never ever get there, because at this stage the patient, you are overdosing the patient. And so the patient becomes apneic, because the respiratory muscles are paralyzed, the pupils become maximally dilated, and the heart stops. There is myocardial depression. At this time is when you get myocardial depression. The patient gets a heart attack or cardiac arrest. And when we give it this when we induce it with this volatile anesthetic, you start low as you move up. So like you started with, excuse me, you are starting like 0.5% of night of allodate. So you continue moving, and you might even get to 5%. But then when you find like you are in plane 2 of the surgical of stage 3, then you need to start reducing the dose to the mark of that drug, so that you don't get to the stage of overdose, which now may lead you to start now resuscitating this patient. So those are the stages of anesthesia, and they were described in 1937 by Guedel, and that is the stage the patient goes through until they are asleep. And so we want to maintain them around the stage of surgical anesthesia plane 1. That's where we want to maintain our patient. When they get there, when they get uh, to the plane 1, plane 2, then we want to maintain it there. We want to keep it at that mark so that the patient can continue now. Because there are some surgeries do and the patient continues to breathe for themselves. You don't want them to get to the stage of overdose. Okay, so now we've done with the inhalational, we've done with the general anesthetics. But the one more thing we want to discuss before we get into the local or regional anesthetics, that we want to discuss muscle relaxants, because muscle relaxants, we use them together with the inhalational and with the and with general anesthetics. So next week we're going to be discussing muscle relaxants before we move to regional or local anesthetics. But then again, we also don't have a lot of time. Remember, we started late, and I don't know how come the semester is a bit short. We may have to plan an online class, maybe in the evening when you can afford, or maybe one of these mornings, early in the morning when you don't have an early morning class, we can do an online class. So I think Moses can organize that and then let me know so that we can plan. I was supposed to collect the cards today. Yes, I was supposed to collect the cards today.
Yes.
So they are ready.
Yeah, they are ready.
So Moses, you
Yes, madam.
yeah, collect them.